Good evening to my friends from Kolkata and to all those who are attending the East India ECHO conference. I was asked to talk about an approach to a newborn with congenital heart disease, critical congenital heart disease. And I actually sought to clarify whether this is just an echo approach or a broad approach. And it's important to recognize that it's important to make the distinction between the two. I'll clarify as I proceed with my talk. At all points, when we listen to a talk, I think it's incredibly important to be sure that we understand why the talk is being delivered. What's the purpose? Why is it important? And that certainly matters much more than how, because if you really care for why it is important, you'll figure out how it is. The how part of it becomes much easier. So it's very relevant to newborns with heart disease because I think today more than ever before, we're able to salvage babies with congenital heart disease. They are important and they are relevant. It's emerging as one of the commonest causes of infant mortality, even within many parts of India. And most importantly, we've shown in many centers, including ours, that many newborns can be salvaged with an incredibly high success rate. And then once salvaged, their long-term survival is excellent. Now, this is a paradigm shift. Since, I would say, last 20 years, this is completely new. And more importantly now, there are more and more governmental sources of funding as well as non-governmental agencies that support congenital heart surgery. So funds can be found if you are determined. This is a study that I was one of the collaborators in, and it's an important study that actually looked to try and estimate the burden of congenital heart disease. And it's a very large global study that showed that incredibly large number of babies die from congenital heart disease, and most of them are from low and middle income countries such as India, China, Vietnam, Indonesia, and this is starting to become a really important cause of death. The prevalence does not change with time or region. So in 1990, in the middle socio-demographic index countries, like many parts of India, like Kerala, now Maharashtra, Punjab, perhaps West Bengal, are all now in the middle SDI category. Bangladesh is actually now being classified as a middle SDI country. Now in this, congenital heart disease was actually already number 4 in 1990 in terms of rank order of causes of death in infants. It has become number 2. In Kerala, we estimate it's number 1. So it's a very important cause of death in babies that is by and large not understood or people are not aware of it. So this substantial increase is most apparent when you have a reduction in causes from other conditions. Like lower respiratory infection has declined, diarrhea has declined. And when we looked at our numbers in Kerala, and this is an IAP study which actually looked at the 2011 census, and we had some good local data that we had gathered from a study here. We estimated that approximately 4,000 babies are born every year in the state of Kerala alone. And that means that there are about 1,500 babies with critical congenital heart disease, and we were just operating on 700 newborns and infants. Now, this is hugely better than rest of the country, but lately this number is now close to 1,000. We are able to almost offer surgery for every baby in the state. And in our own institution, nearly 20% now are newborns. So the rest of the country, the situation is much, much worse. If you look at it, there are a substantial number of babies born every year with congenital heart disease, and the number operated are only 10%. And that's because the centers are all clustered in southern India and in the metros. For large parts of the country, there is no access to congenital heart surgery, and therefore, neonatal heart disease hardly ever figures in the consciousness of people living in these parts of the country. But it's important, and it's going to get more and more and more important. Outcomes have been much more optimistic, and this is our own center's data in Amrita Institute, and we have a very robust database of congenital heart surgery that we have been maintaining for the last 11 years. And we've looked at two commonest corrective operations in newborns in the last 10 years. One is TAPVC, and we have done approximately 150 neonatal TAPVCs with a 2% mortality. And transposition, 192 operations, 1 death, 1.2% mortality, and a very impressive data on survival only because these are correctable conditions and they come to us early. So that's the essence, really. You need to have a situation where these are identified and referred early. So what is the echo? So with this background, you have to sort of, when you see a newborn with congenital heart disease, I think you need to recognize that this is not esoteric. This is something that is common, relatively common, when it comes to a cause for death in the newborn. So when you approach an echo, we have some very essential facts. Echo is not critical to stabilization. So there is no need to rush to echo whenever you suspect heart disease in a newborn until you have stabilized the baby. But once you have stabilized, echo is critical. Critical to accurate diagnosis. It enables correct management because you need to have a comprehensive echo, complete diagnosis, and a complete understanding of physiology. The requirements are important. You can't, by and large, do with a low end machine which is portable. You need a fairly good quality machine because you need to have a very high level of resolution. It's important to have pediatric and neonatal probes. Neonatal probes go towards up to 12 megahertz. And they're very important when you start looking at very fine structures, like when you're looking at coact, duct insertion. When you start looking at structures that are so thin that they'll be missed, the ultrasound beams from low frequency transducer will just go through them, will not get reflected. You need the high frequency transducers which don't have to penetrate very deep. You don't need speckle track. You don't need all those features that you need for quantification of diastolic function, tissue Doppler. None of that is necessary in a newborn. What you need is a good probe, a good 2D, and a good color. Good resolution, accurate, high quality images. Everything else is fancy stuff. 3D, not required. Unfortunately, the echo machines are now packaged with all these extra features that actually end up making the machine cost a lot more. But what you need is essentially good images. The operator who does this echo should know what is really, should understand congenital heart morphology. Without that understanding, if the operator does echo, you will not be able to interpret. So that is a basic requirement. And it's not difficult to really get that understanding. It takes a month and you can be pretty good at echo after that. It's also important to understand the transitional physiology. The physiology changes, and during this course of development of the heart, as the child is born, from the point that the child is born, the physiology is very transitional. Pulmonary vascular resistance falls, the PFO closes, the duct starts to close. So these changes you need to have a good idea of. And ideally, you should be the one, the person who does the echo should also be the one caring for the child with heart disease. When there is a disconnect between the two, there is a lot of errors that creep in. So as far as I am concerned, I keep encouraging neonatologists to learn how to do echo. The biggest disconnect happens, with all due respect, is when adult cardiologists start to do neonatal echoes using adult machine with adult settings. You have host of errors that come in. It's very important that you really have to appreciate these elements, or you have to recognize that you'll be making mistakes. And we see them so often. It's surprising. The scenarios that you do echo are a stable newborn that is not in distress. They come to you in a very nice, pristine state, and you just have all the time in the world to make the diagnosis. Or you have a very distressed baby. Now, that's a very stressful condition. Baby is toxic, is hypoxic, tachypnic, is at the risk of having a cardiac arrest, and you need to do something. So in those circumstances, it's almost always preferable to stabilize the baby. You may target your echo to answer a few questions, but that's often not very helpful. It's important to stabilize the baby and then bring the baby back for a thorough, proper echo. You can have an in-between situation where you have a reasonable level of time, and if you are quite an expert, you can figure everything out and quickly send the baby back to the ICU for management and also have a plan. Then the third circumstance is when you call to the NICU, baby is sick on a ventilator, and now you have to give an opinion. That time you again have things under control, more or less. You just have to be mindful and respectful of the environment, sterility, lighting, machine, etc. But you can use that environment and come and actually come up with a very accurate diagnosis. So when you have distressed newborn, now that's the scenario I think that frightens everybody. I'll quickly go through 3 case scenarios. So here is a firstborn cesarean section delivery with poor feeding, sent home after delivery. Nothing was found amiss. Baby went home, had poor feeding, mild tachypnea since birth, and cyanosis noticed by grandmother, 3rd week. Then worsening distress, my grandmother was convinced the baby is not doing well. Everybody else, including the pediatrician, was also thinking that the baby is okay. But eventually the baby was brought tachypnic, grunting, desaturated. Despite giving room air saturation of 70%, the saturation was only 70% with full oxygen. Single loud P2, no murmurs, liver enlarged, and this was the X-ray. So when you have this scenario, you actually don't really need an echo machine to arrive at a diagnosis enough for you to treat the patient or stabilize the patient. You don't need an echo to be able to stabilize this patient. This child is sick, distressed. You can stabilize this patient. You can intubate the patient. You can ventilate the patient and make sure that the vitals are acceptable, the oxygen delivery is reasonable, and then calmly do the echo in this circumstance. But I'll come back to the diagnosis here subsequently. Case 2, again sent home. Cesarean delivery, sent home. 27th day, child found to have deep cyanosis, really sick, brought with profound metabolic acidosis. No question, you can't even wait for an echo, ventilation, stabilized, and then referred to us on a ventilator. And this is the patient. This is the X-ray. I want you to take a look at the X-ray. And then the third child. Third child is very interesting. This is a child almost never comes to the cardiologist because the child was essentially doing well, delivered, and sent home again, day 3, day 2. But on day 3 started to have poor feeding. On day 4 became really sick, drowsy, no cyanosis, but started to have seizures, circulatory collapse, ventilated on multiple inotrops, labeled as sepsis. But was one thing noted by the resident who accompanied the baby to our hospital, that the brachial artery was palpable, carotids were palpable, others were not palpable. He didn't know how to interpret this, but this was a very important clue. Of course, the patient had lots of end organ injury and they were all labeled as sepsis, but then we were called and then I'll tell you the diagnosis. So let's look at the 3 conditions. The first is a TAPVC, obstructed, because it's white lungs, big heart, blue baby, hazy lungs, and this is something which is characteristic of obstructed TAPVC. Now, if you don't know this and you do the echo, I've seen numerous cases of TAPVC being missed on the echo because nobody thought of it. And if you don't think of it, you will miss TAPVC, especially infracardiac. This is duct-dependent pulmonary circulation. You don't need an echo to demonstrate. Blue baby, black lungs, small heart. You don't need an echo. You need an echo to refine your treatment. You need an echo to understand what it is. But you can start prostaglandin on this baby without an echo. You don't need to wait for an echo. Then circulatory collapse, multi-organ injury, discrepant pulses, start prostaglandin. Of course, you can get an echo eventually, but this is duct-dependent systemic circulation. So the initial diagnosis, the initial condition recognition does not necessarily require an echo. It requires awareness, it requires understanding, and it requires screening. If you screen every baby with a pulse oximetry, you will pick up all these three conditions. You have a post-ductal saturation less than 95% in all these three conditions. So those are the ways in which you can approach picking up congenital heart disease at a population level. The role of echo is much more specific. And those are that you actually want to make an accurate diagnosis for the purpose of surgery. And the rules that you follow when you do an echo is that you adopt the same approach for every newborn, for every infant, but not necessarily, you don't tailor the approach. Saying, okay, I'll do this for cyanotic babies, I will do this approach for acyanotic. It doesn't work that way. Disciplined, systematic, uniform approach, irrespective of the underlying suspected disease. Display anatomically correctly, and I have this issue with adult cardiologists. I think a big barrier to their understanding of cardiac anatomy is because they just don't display the anatomy correctly. So the so-called inverted images that we use are the correct images that we use. And trying to look at everything in the adult style, because it doesn't work, because in adult style, you're not trying to figure out morphology. And then stay oriented. Where is your transducer? Very important, because dextrocardia, situs inversus, you've got to stay oriented where your transducer is. And then more importantly, you figure out things when you move your transducer. In adult echoes, you just put your transducer, get a fine image, and try and get the most information out of that image. Here you get the image and also sweep in specific directions consciously and get information. And then complete a very, very important 15-item checklist. After you've completed the checklist, you must correlate clinically. If your diagnosis does not explain cyanosis, baby is blue, and you have diagnosed everything to be okay. I've seen that happen. Transposition missed. Patient reported to have a normal heart because nobody bothered to check and correlate the fact that child is deeply blue. Similarly, TAPVC gets missed because people don't actually try to explain the clinical condition. So correlate clinically. So the checklist is cardiac position, situs, systemic veins, pulmonary veins, atria, atrial septum, AV valves, ventricles, ventricular septum, phonotrunkus or outflow tracts, branch pulmonary arteries, aortic arch, PDA, other specific items, and then physiology. You've got to have this 15-item checklist sorted out at the end of it. And as you get better and better, sometimes it just takes 10 minutes to do this whole thing. But if you don't do this, you'll make mistakes that will cost lives. Babies will die from seemingly small errors. So it's very important. So there are some, and honestly, this lecture should probably end here because this comprehensive approach you have to do in every baby. Nonetheless, I will indicate the common errors that are made quickly so that we complete our understanding of where the sources of error is and try and correct them. So the errors can happen in one of these 7 things, and we'll go with them systematically. Situs. It's surprising, if you miss the situs, you can go completely off. When you're on the wrong track, every station is the wrong station. So get your situs right, it is terribly important. So this are some examples of situs. On the left is situs solitus, situs inversus, and situs ambiguous. And you do that by sweeping in the abdomen, in the axial plane, identifying IVC and the aorta and sweeping them towards the heart to identify where the IVC drains. This is situs solitus, this is situs inversus. So in example, in a situs inversus, you will see the IVC on the left side, the liver on the left side, the aorta on the right side, and you sweep up, you'll find the hepatic veins going into the left-sided right atrium. So this is very important. And then if you further sweep up, you realize all the structures are mirror image of each other. It's very, once you're systematic, you got your situs right and you're going stepwise, you won't make mistakes. Second source of error is systemic veins. Surprisingly, it's important. Here's an example of unexplained cyanosis in a newborn. The patient had an LSVC going straight to the LA. And this wasn't picked up. Nobody thought of it. And when in doubt, you could even do a contrast echo, but here it was pretty obvious once you interrogate the LSVC. So IVC interruption is very, very important because a host of abnormalities are associated with polysplenia, and it has so much implications. So you must track the IVC, and it's much commoner than you believe. And you can see that the hepatic veins are going alone into the right atrium, and the azegus is lying parallel to the spine, close to the aorta, and having nothing to do with the heart. The biggest pitfall, one of the biggest pitfalls, pulmonary veins. Maximum errors here, because you have to be systematic about it. So the first thing is you need to know how you normally look at the pulmonary veins. And here you should identify all four, not three, all four. And you can see that here we are seeing the right inferior, right superior pulmonary vein. And this is a modified high parasternal short axis view. You can see the left superior, you can see the left inferior. All very easy to identify. If you spend a little time, adjust your scales, identify the structures, you can identify the pulmonary. Of course, subxiphoid is also very useful. The other clue that you get for TAPVC is the atrial septal defect, which shunts, in this particular case, completely right to left. When you have a completely right to left shunting across the ASD in a newborn, you've got to get really worried. You're dealing with super high PVR, or you're dealing with TAPVC. So when you get that situation, you start to get worried. Could be a TAPVC. Now the most common TAPVC that's missed is this TAPVC, infracardiac, where you see this channel going into the portal vein, and then if the ductus venosus is open, it goes back through the ductus venosus into the heart, and the patient is relatively stable. But once the ductus venosus closes, it has to traverse the entire portal system to get back to the heart. Patient becomes very unstable and develops pulmonary hypertension. This is one of the commonest misses in a newborn. And it's easy to understand why it's missed. The structure is behind the heart. It's very difficult to look at the individual pulmonary veins. In this case, you have a very hypoplastic left upper pulmonary vein. And they come back and join relatively lower in the thorax. So this, unless you're suspecting and you see this big vertical channel, you tend to miss this. And even after diagnosing a TAPVC, sometimes you need to do the CT to refine the anatomy perfectly. Another case where you miss is in visceral heterotaxy, where you have atrial septal malalignment. You can miss the TAPVC example. And this is another common error. And this patient is labeled as an ASD, but is very sick and somewhat blue. Here is a better example of atrial septal malalignment, where all the pulmonary veins are ending up coming in the right atrium, and you have a restrictive ASD, which results in exactly like a TAPVC, but the patient can be very disproportionately sick. The important pitfall is PDA. Now, PDA, you can have PDA missed altogether because you're looking for this high velocity flow. But if PVR is high, you get laminar flow or very low velocity flow. You have to turn down your scales, image 2D to perfection, and then see your PDA. The vertical PDA is also very important because you see it in pulmonary atresia in a variety of circumstances, and it's important to identify it and define its insertion, because nowadays we're doing a lot of ductal stenting, and we need to understand this anatomy really well. Branch PA is critical. You have to define them to high degree of precision. Because you send the patient for a BT shunt and you have branch PA origin stenosis, you can have a very different result. So you need to be super precise. I'm showing you an angiogram just to show comparison, how you can define the branch PAs in a high parasternal short axis view, very conveniently located behind the thymus. Arch-sidedness, very important. You can easily do it in every single patient. You can see the trachea. As you can see out here, you can see the aorta, and you can see the aorta fall on the left side of the trachea, and you can trace the individual branches, and you can look at the coarctation. Spend time, high frequency transducer, patience, absolute meticulous imaging. Every segment of aorta should be measured, and you won't miss coarctation. Again, right aortic arch is an example. I'm just showing you where it can be identified, and you can get this information very useful in vascular rings, for example, in a newborn who presents with stridor. It's too extensive to cover in this one. I just showed you some examples with the idea of just telling you where the pitfalls are, but there are many more pitfalls, to be honest. Pulmonary hypertension is a very important one, because not understanding this changing pulmonary vascular resistance in a newborn results in a lot of errors. And not, labeling pulmonary hypertension as suprasystemic when you have an unrestrictive VSD. Trying to chase the TR jet when you have an unrestricted VSD, unnecessary. When you have a tiny TR jet and you have a large VSD or a large PDH, the PA pressures will be equal to aortic pressures. So understanding physiology and putting things in perspective after understanding physiology is very important. So to conclude, echo should be systematic, unhurried, comprehensive, irrespective of what the clinical condition is. It should explain the clinical condition, and it should enable complete planning of management. Thank you.